Thank you for the opportunity to present our research today. It is well known that female athletes with low energy availability are at risk for hypogonadotropic hypogonadism, impaired skeletal integrity, and bone stress injuries. Whether an analogous syndrome occurs in male athletes as well as its potential mechanisms has not been well studied and was the objective of this cross-sectional study. We enrolled 31 men aged 16 to 30 years, 15 runners, and 16 non-athlete controls. Inclusion and exclusion criteria are as shown. The protocol included tibia and radius volumetric BMD and microarchitecture by HRP-QCT, estimated bone strength by FEA, body composition by DEXA, and serum testosterone, estradiol, and leptin levels. HRP-QCT variables measured included cortical and trabecular volumetric BMD, cortical porosity, the percentage of the cortical bone volume that is porous, trabecular number, or mean number of trabeculae per unit length, trabecular separation, the mean distance between trabeculae, and failure load, the force necessary to break the bone. Importantly, higher volumetric BMD, trabecular number, and failure load, while lower cortical porosity and trabecular separation, are associated with greater bone strength. Clinical characteristics were similar between groups, except miles run per week, as expected. We demonstrated that mean tibial cortical volumetric BMD on the y-axis was lower in athletes in red than controls in purple, and mean tibial cortical porosity was higher in athletes than controls. Radial cortical variables were not different between groups. These data suggest that athletes have inferior tibial cortical volumetric BMD and microarchitecture than controls. Now turning to trabecular variables, mean tibial trabecular volumetric BMD was higher in athletes than controls, as was mean tibial trabecular number. In addition, mean tibial trabecular separation was lower in athletes than controls, and radial trabecular variables were not different between groups. These data suggest that athletes have superior tibial trabecular volumetric BMD and microarchitecture compared to controls. Mean tibial failure load was lower in athletes with a BMI of less than or equal to 21 kilograms per meter squared, here in orange, compared to athletes with a higher BMI, here outlined in red. These data suggest that low weight, a proxy for low energy availability, is associated with impaired tibial bone strength in male athletes. In athletes, lean mass was positively associated with tibial failure load, with lean mass here on the x-axis and tibial failure load on the y-axis. Fat mass was not associated with tibial failure load. These data are consistent with studies in other populations demonstrating that lean mass is a positive determinant of bone strength. Also in athletes, estradiol, converted from testosterone and adipose tissue, and here on the x-axis in the figure on the left, and leptin, reflecting lower fat mass, and here on the x-axis in the figure on the right, were positively associated with tibial failure load, but total testosterone levels were not. These data suggest that hormones secreted by adipose tissue are determinants of bone strength in male athletes. In conclusion, despite weight-bearing activity, male runners have impaired tibial cortical volumetric BMD and microarchitecture, which may increase cortical bone stress fracture risk. Lower leptin and estradiol, as well as less lean mass, are determinants of lower tibial strength in these athletes. These data suggest that low energy availability is a risk factor for impaired bone strength in male runners.